will be Dr. Shrinivas. Dr. Shrinivas is from the Department of Anesthesia, JSS Medical College. I request him to come to the podium, please. Management Anesthetist. He is Executive Committee member of Indian Society of Karnataka. He has published a lot of national and international publications. He has presented guest lectures. He has been an NA-based internal counselor and a lot of other things with him. I request him to present his paper, please.
Thank you. Thank you, sir. Good afternoon. Good evening, everyone. I thank the organizing committee, scientific committee, to provide me this opportunity. I will be talking about lung isolation techniques and challenges. Particularly, I have skipped anatomy and physiology over here to accommodate time. Single lung ventilation or one lung ventilation involves ventilating one lung, letting the other collapse to provide adequate surgical exposure in thoracic cavity, and or isolating the other lung. The protective role of single lung ventilation involves protecting one lung from the ill effects of fluid from the other lung, which may be blood, lavage fluid, malignant or purulent secretions. Perfect placement of the tube is very much essential, as misplaced tube defeats the goal of one lung ventilation, or commonly known as differential ventilation. Bronchoscopy after tube placements ensure proper placement, and familiarity with the use of these instruments and the physiology of single lung ventilation is very much essential to the performance of a safe anesthesia. Single lung ventilation is used to facilitate procedures on ipsilateral thoracic structures, mediastinal structures, and to provide lung isolation. This is made possible by using double lumen tubes, bronchial blockers, and endobronchial tubes. What are the indications? One is foremost important is surgical exposure for VAT surgeries, including pneumonectomy and wedge dissections, pulmonary resections, including pneumonectomies and lobectomies, mediastinal surgeries, thoracic vascular surgery, esophageal surgery, spine surgeries, and minimally invasive aortic and mitral valve replacement surgeries. Second indication is lung isolation for protective purpose in case of massive pulmonary hemorrhage, infection and purulent secretions, and while doing whole lung lavage. And third indication is for control of ventilation to decrease pressure or airflow through the affected side in case of tracheobronchial trauma or bronchopleurophoncocutaneous fistula, and we need to avoid ventilating that particular lung. What are the contraindications? Patients unable to tolerate single lung ventilation, intraluminary airway masses making DLT placement difficult, hemodynamic instability, severe hypoxia, severe COPD, severe pulmonary hypertension, and a known or suspected difficult intubation are the common contraindications. Choice and type of device is left to the operator's preference and how much he is trained in those. There are three different ways to achieve lung isolation and one lung ventilation. As I said, double lumen bronchial blockers and single lumen tubes. We will go detail into double lumen tubes. DLTs are most widely used, and it was first introduced by Cullen in 1950s, and it is a bifurcated tube with separate tracheal and endobronchial lumen that can be used to ventilate either lung independently. PVC modified Robert Shaw tubes are now widely used. The parts have been, you might all been using them. The tracheal lumen is designated to terminate above the carina. Bronchial lumen is angled to fit into appropriate sided main stem bronchus. In case of left DLT, it fits into left main stem bronchus, and vice versa. The bronchial cuff is and the pilot balloon both are usually colored blue for easy identification. There are two types of DLTs, I mean right sided and left sided DLT. They differ in basic design. The right main bronchus is shorter, straighter and wider than the left one. The right upper lobe bronchus takes off very close to the origin of the right main stem bronchus. That's why the right sided tube has a modified cuff and side opening inside the cuff itself, known as Murphy's eye, to allow endobronchial tube to allow ventilation to the right upper lobe. What type of DLT is needed? Most of the elective we usually do most of the one lung ventilation with the left sided tube itself. However, in some situations, right-sided tube might be used, whereas such as surgery involving left main bronchus, left pneumonectomy, left lung transplant, left tracheobronchial disruption, left-sided thoracoscopies, and aneurysm of the descending thoracic aorta and tumor compression. Sizes: adult DLTs come in size 35, 37, 39 and 41 French. A properly sized DLT is one that passes easily through the glottis and advances without resistance into the trachea and fits into the bronchial component, easily fits into the intended bronchus. The most accurate method of selecting size is to measure the bronchial diameter of the left main stem bronchial diameter from a CT scan. Typically 37 and 39 are used for female and males. DLT insertion, I will show a small video. Before that, the steps: check the integrity of the tracheal and bronchial cuffs, lubricate outside of the DLT, lubricate and insert a intubating stylet into the endobronchial lumen, perform direct laryngoscopy and visualize the glottis, advance DLT till endobronchial cuff has passed beyond the vocal cords and then remove the stylet. Rotate DLT 90 degree clockwise or anti-clockwise depending on the type you are using, left one or right one. Pass the tracheal cuff beyond the glottis and until the resistance is noted. The depth of insertion of DLT correlates to the height of an average size patient. The formula is 12 plus patient height in centimeter divided by 10. Confirming, it's a 3-step process. First step, inflate the tracheal cuff with minimal volume to seal the glottic leak. Then perform positive pressure ventilation and then auscultate to confirm bilateral air entry and obtain a capnography trace. Then step 2 is to clamp the tracheal limb of the breathing circuit and disconnect this from the tracheal lumen. Inflate the bronchial cuff and ventilate. Auscultate to confirm unilateral ventilation with no leak. Third step, release the tracheal lumen clamp and confirm the resumption of the bilateral air entry. Foremost important is fiber optic bronchoscopy or flexible video endoscope confirmation of this position. For right-sided, what we have to note, insert the fiber optic scope through the endobronchial lumen and ensure the Murphy size aligned perfectly with the right upper lobe bronchus. It should not be mismatching. And for the left-sided, insert FOB through the tracheal lumen, visualize the carina first, and then identify the blue colored endobronchial cuff as a thin crest within the left main bronchus. And after inflation, the cuff should not be herniating into the carina. What are the complications? Most common complication is malposition, most common problem also, and small malpositions are usually insignificant. Major malpositions causes inadequate collapse of the intended lung and hypoxemia and inadequate surgical access. Common causes of malposition include dislodgement of the endobronchial cuff due to overinflation and extension and flexion of the patient's head or neck and surgical manipulation. Other complications include airway trauma and tension pneumothorax. What are the advantages of using DLT? They are quickest to place. Suction and bronchoscopy of the isolated lung is possible. CPAP to the operated lung is possible. Can alternate one lung ventilation. Either we can, even with a single tube, either you can choose to ventilate either left or right. Intraoperatively also we can shift or change. Can insert even fiber optic bronchoscope even if it is not available. Older days they used to use rubber tubes, rubber shot tubes, even when fiber optic scopes were not available. What are the disadvantages? Limited sizes are available, difficult to place in abnormal or distorted airways, not ideal for post-operative ventilation, and potential airway trauma risk is always there, and intraoperative displacement is one of the complications with. Here I have a video and I have muted it and so that I can talk. So he is placing a double lumen tube. So as the patient is positioned, hold the tube in the right hand, scopy is done with the left hand, and then introduce the DLT into the oral cavity and then rotate it 90 degree. After it proceeds, goes beyond trachea, vocal cords and then you can see the vocal cords there, and then after the tracheal cuff enters, we have to turn 90 degrees to either side, then connect the connectors, tracheal and bronchial, then inflate the tracheal cuff with 5 to 10 ml of air or saline, and then the bronchial we should not exceed 3 ml, which is the limit. If you exceed, chances of displacement is most common, and then he is checking, bilateral air entry is checked, and then we can clamp tracheal and bronchial alternatively to check one lung ventilation. Then coming to bronchial blockers, an alternate technique is to use bronchial blockers. It prevents ventilation distal to the occlusion. Then they can use to provide selective lobar collapse as well, and they are either placed with either intraluminal using a single lumen tube, which is coaxial technique, or separately adjacent to the single lumen tube. I will show the video also. Various bronchial blockers are used: univent, Fuge uni blocker, ANT wire guided endobronchial blocker, Cohen tip deflecting, which has a wheel within it. We can use the wheel to deflect the tip, and Rush bifid EZ blocker, which sits at the carina and bilaterally both sides of the lungs can be blocked. Advantages: easy size selection, easily used with a standard tracheal tube, and easy placement, selective lobar lung isolation. Disadvantage being time consuming, and we always need fiber optic. Difficult to alternate one lung ventilation except for while using Rush EZ bifid blocker. This is a small video here. Here ANT bronchial blocker is being introduced. Single lumen tube is in place, and then this is the contraptment where it has 3 ports, one for ventilation, one for fiber optics scope, and another for bronchial blocking catheter. So it should be arranged, then connected. Ventilator for ventilation port is connected, then catheter is introduced by the side port, and fiber optic is introduced, and then this is the coaxial technique. And when it reaches under the fiber optic guidance, the placement of the brachial blocker should be confirmed, and the fiber optic device can be withdrawn. This is the fiber optic device assisting the placement of the brachial catheter, brachial blocking catheter. Then once we reach the intended side of the lung, the cuff is inflated and fiber optic is withdrawn. You can see the cuff in place. Okay. And single lumen tubes, it can be used in pediatric patients, where it can be guided into one main bronchi and selectively ventilate, allowing gradual collapse of the other lung, which is not possible with the adults, and not always we cannot do this. There are some certain lung protective strategies to avoid acute lung injury and ARDS while doing one lung ventilation, such as setting tidal volume to 4 to 6 ml per kg body weight on an ideal body weight, airway pressure maintaining less than 30 centimeter of plateau pressures, then respiratory rate maintaining 16, ABG should be sent 30 minutes after initiation, and if PaCO2 is more than 40, increase the respiratory rate. If the PaCO2 is less than 40, then respiratory rate can be decreased. Inspiratory flow rate kept at maintained at 60, and ensuring PEEP is set at 5 to 10 centimeter H2O, and then I am into the last minute. So oxygenation goal of 88 to 95% should be enough, and frequent recruitment maneuver should be carried out. What are the complications? Hypoxemia is one of the complications, and acute lung injury is one more complication. So to avoid while anesthetic management is carried out, particularly mechanical ventilation can influence the extent of perioperative lung injury. So for this reason, we have to carry out the protective strategies what I just recommended. To conclude, optimal technique of lung isolation will depend on several factors, including indication of one lung ventilation, patient's airway, and studying his airway using scans, and expertise of the anesthetist and availability of all these equipments. It is crucial to understand the patient's laryngo-tracheobronchial anatomy, review relevant imaging technology. Thank you.